Hello colleagues, this is Professor Dr. Sameen Afzal Junejo from Afzal Eye Clinic, Hyderabad, Sindh, Pakistan. Dear friends, I will show you a video. Yesterday I performed a cataract. A person who was suffering from chronic simple glaucoma along with lenticular changes, grade 2. He was operated for a triple procedure surgery which included trabeculectomy operation associated with Phaco emulsification and IOL implantation. First of all, a fornix based conjunctival flap was created. Dissection was done with a round iris scissor. Conjunctiva was separated from sclera along with the Tennant's capsule, and the flap thus made was a fornix based flap. The Tennant's capsule was further dissected and all the area was cleared of any underlying tissue. Pupil was very much dilated in this patient and the intraocular pressure was normal before surgery with adequate anterior chamber. Cornea was clear. After dissection of the conjunctiva, mitomycin C soaked cotton bud was put on the dissection area for about 4 minutes, and then the area was thoroughly washed with irrigation solution including the Ringer solution. As the glaucoma was not very much long standing and it was a chronic simple glaucoma with wide open angle and the patient was not too old, therefore the triangular pattern or V pattern, half thickness scalal flap was created. And this V pattern scalal flap was limbal based. Dissection was completed up to the gray line or the termination of the Descemet's membrane of the cornea, where white meets blue. Sholby's waits for you. We should avoid the dissection of the Sholby's line, and whenever we try to create a window beneath the scalal flap should be away from the Sholby's line or the blue line, so that there should be no any injury to the corneal endothelium, detachment of the Descemet's membrane of the cornea, and further future corneal opacities or endothelial dysfunction. A cystotome was passed through the surgical limbus alongside the V pattern half thickness scalal flap and a round regular curvilinear capsular rhexis was performed. With the diameter of the rhexis of almost 5 to 5.5 millimeters. A diamond keratome of 2.78 millimeters in diameter was used to create full thickness two-step tunnel corneal incision. And a side port was also formed at about 12 o'clock position with a diamond straight stab keratome. This side port incision is always done in order to facilitate the chopper. Viscoelastic solution was injected and hydrodissection along with delineation was performed with the help of a ringer solution. Phaco tip was used, and that was an easy tip, and this tip was used to perform a phaco emulsification of the nucleus. The nucleus was turned around and the phaco emulsification was performed through the equator of the nucleus, keeping the bevel of the phaco tip lateral but not up or down position, so that the ultrasound whatever used should not head towards the endothelium of the cornea, thus saving the endothelium from going into the postoperative complications. The vacuum in this case was 550, ultrasound was 55, and the flow rate was 40. This phaco emulsification was performed under high vacuum with minimum phaco energy. Viscoelastic solution was injected to facilitate the irrigation and aspiration of the cortical matter with the help of a two-way Simcoe cannula, my favorite instrument. With the help of a Simcoe cannula, the irrigation and aspiration procedure is very much controlled and perfectly done in presence of a OVD dispersive. The side port was used to remove the cortical matter which was trapped at 3 to 6 o'clock position. Very carefully just to save the posterior capsule and the corneal endothelium. Viscoelastic solution was injected again prior to the intraocular lens implantation into the bag. In this case, a one-piece foldable intraocular lens was implanted by the injector, and this intraocular lens is preloaded into the injector. This intraocular lens has got a very good and stable haptic memory. There is no need of positioning the intraocular lens into the bag by means of a dialer. A cocktail injection containing the pilocarpine, moxicon and the dexamethasone just to achieve the meiosis, and then with the help of a number 11 surgical blade, a small triangular window was created by piercing into the scleral bed underneath the half thickness scleral triangular flap. A peripheral buttonhole iridectomy was performed with the help of a corneal forceps and straight venous scissor. This iridectomy was performed anterior to the outer margin of the ciliary body in order to avoid excessive and vigorous surgical bleeding. So ciliary processes and ciliary body, which is slightly darker in color than the iris, should not be intervened at any cost. And then the scleral flap was closed by applying 3 10-0 nylon monofilament non-absorbable sutures. Conjunctiva was repositioned by applying 1 10-0 suture with buried knot, and the dissecting area including the scleral flap was completely covered with the repositioning conjunctiva just to avoid postoperative leakage of the aqueous humor. Anterior chamber is well formed pupil is small and round. It is not trapped into the filtration bleb area, and the iridectomy is very clearly visible through the cornea. A buried knot suture is applied at the conjunctival margin and the dissecting area completely covered. Conjunctiva is lining the upper limbus of the cornea. In this way, we completed the triple procedure: trabeculectomy, phaco, and intraocular lens implantation surgery. The anesthesia was subti non-anesthesia in this case. Thank you very much. My dear colleagues, if you have liked this video, then please press the bell icon, press the like button, and subscribe my channel. Thank you very much. Good luck.